Hello, my name's Greg Goodman. I talk to you on behalf of 12 authors, Mark Magnuson, Peter Callan, Stefania Roberts, Sarah Hart, Frank Lynn, Ekram Rahman, Cara McDonald, Stephen Liu, Kath Porter, Neve Cordiff and Michael Clegg. And I'm going to make the case in the most important development reflected in my study that aspiration before tissue filler injection is a waste of time and dangerous. It's a waste of time because there are two concepts, negative aspiration and positive aspiration. Negative aspiration may be true and may be false negative. True negative aspiration is blood not coming back and you not being in a vessel. False is when your blood is not coming back, but you are in a vessel. So we're probably in vessels all the time. And when we negative aspirate, we find that most times we get a negative answer to that aspiration. Does that mean that it's a good safety maneuver? No. One, you can't clear the product from the needle and the syringe with many of the current products. It's been shown in a number of articles. Two, when you inject vertically and stay stable, you're probably occupying a number of tissue planes, some of which are safe and some which are not, especially in thin-skinned areas, and you would get a negative aspiration most times. Three, you can collapse your vessel with the pressure of negative aspiration. Four, you can skewer past the vessel, get a negative aspiration, but still be injecting along that track left from the needle or the cannula backwards into that skewered vessel. Five, you can actually have moved your tip of your needle from the point that you think you're in and get a negative aspiration at the beginning, but have moved into a vessel at the end. The positive aspiration status is also similar in that you may get a positive aspiration, and that's fine. But the problem is that by the time you've got that positive aspiration, you've probably moved out of the needle place anyway. So there are so many reasons why aspiration is not useful. And there's no evidence to suggest that it is useful. No articles have actually shown that it is a useful mechanism. Similarly, people talk about priming their needles. That is impractical and also doesn't help the movement situation. If you aspirate for 1 second or 10 seconds or 0.2 mil pull or 0.5 mil pull has been suggested in a number of articles, yes, you've got more chance of getting positive aspiration after a longer pull or a longer duration of a pull. But realistically, that also means that you're going to move your needle substantially from the point of origin. What advice I give colleagues or trainees who want to implement and replicate this procedure? Don't do it. Don't aspirate because the result of the aspiration is the issue. It's a resultant bolus because you have to stay still after you aspirate, otherwise it has no meaning. And the resultant bolus or the resultant embolism intravascular, if you've got it wrong, is significant and will actually be most likely cause of things like blindness, intravascular event of great importance, or cerebrovascular event. What's next? What's next is to think about doing other safety maneuvers, movement, move, small boluses of injection, less than 0.1 mils. Always be thinking about low pressure injecting, always understanding your anatomy. And obviously we'll be doing more studies in aspiration to show that that it is a flawed technique. So thank you for your attention, and I hope this has meant something to you. Thank you. Bye.